Welcome, everybody. We're going to start in 20 minutes.
Hello, John. How are
Hello.
you?
How you been?
Hello, how are you, John?
Good. How
I'm
you
from
been?
Bangladesh.
I'm sorry?
Hello, John. I'm from Bangladesh.
Oh, good. There's another doctor that comes from Bangladesh pretty regularly.
Hey, how are you?
Good,
John?
good. So I'll
So
be
many
back.
days
I
we
got
are
to do some
talking.
last minute stuff.
Yes, there is a lot of works.
Little stuff, administrative stuff. I'll be back.
Okay. Okay.
Dr. Ihanga. Can you hear me okay?
Yeah, can hear you, sir.
Oh yeah,
I've
your
sent
voice,
you-
your voice sounds good.
Yeah, I've sent you a WhatsApp with the topic I'm
Yeah,
going
yeah.
to present.
Let me show you.
Yeah, the
See,
new
like
one
this.
updated.
You see this?
Yeah, this one I sent just now.
Okay. How do you go backwards? We go backwards.
Will it work well? Yeah.
Okay, I want to start at the beginning. How do I start at the beginning?
Yeah.
Here? Oh, I gotta start from the beginning, I guess.
Yes, sir.
Okay.
Yeah, that one. Yeah.
Well, I'll leave it there. go one by one. Hello, Amir.
Yes.
Hello, John. Hi, everyone. Hello,
How you
John.
been?
Great.
Okay.
Yeah,
Yeah,
that's good.
welcome. sir. Mm,
Thank you,
How are
man.
you?
Thank you. Great, in this tough situation, this quarantine time, we are, just studying right now, something like that, and researching and so on. Thank you, John, for inviting me, to
Yeah,
this.
I'm glad you're coming. We
Thank
have
you.
them every day. I don't know if you saw it, Edie,
Yeah, I saw them. Yeah, I saw them on
in
YouTube.
neurosurgery every day.
Yeah, I saw
Yeah.
them on YouTube and LinkedIn, and but I didn't have the time to join, unfortunately.
Oh, okay.
But now, I made the time. So
Okay, let me check. I gotta, what, hold on. Okay. So you remember how to do it, right, Dr. Hanga?
Yes, sir.
And just let me know, just say next, next.
Yeah, I will do it.
It works. We've done it before. It makes it a heck of a lot easier.
Yeah.
Hello, Dr. Kabulo. Who else is out there? Nabaz, Adria, Rizwan. Now, I don't know how good you guys
How
are.
are you?
Hey, Dr. Kabulo, how you been?
Good.
Doc, welcome, Doc. How are
Thank
you?
you, Dr. Yang. How are you?
I'm fine. I can
Well,
see you.
You guys know each other?
Welcome.
Yes.
Yeah.
How do you know Dr. Kabulo?
Sorry?
How do you know Dr. Kabulo?
No. I don't know him. I know him just here.
Oh, okay. That's right. You're Congo too, right?
Yeah, he's also from Congo.
Yeah. Okay.
Oh, that's good.
And
Dr.
that's what your study's
Kabulo,
about, right? That's what
good
your study.
evening.
Good evening, Dr. Yang. How are you?
I'm fine. Where are you from?
Lubumbashi.
Oh, are you presenting from Lubumbashi?
Yes, I'm in Lubumbashi, but I'm training in Zimbabwe.
Yeah, that is great. I'm also from Kinshasa, but I'm training here in Kampala, Uganda.
Well,
Wow.
excuse
Nice
me,
to meet you.
excuse me, Edith. Does it matter to you whether you go first or second? What would you prefer?
Sorry?
Would you mind if Victor went first? Victor Hugo Perez? He has a lecture. Do you mind if he presents first, or do you want to present first?
Yeah, if he's demanding to start, he can start. Maybe he has something to do after.
Yeah,
But
let me
if,
ask him. Let me ask him, okay? Victor,
Okay.
Victor, you can hear me, right? Victor? Let me see.
Hello.
Hey, Victor, can you hear me? Victor, ¿puede oírme? Well, if you can't hear me, we're gonna start. We'll start quick. Maybe had some connection problems. Hey, Victor, can you hear me? You may have stepped away.
Hello. Hello.
Hey, Victor.
Yes.
Hey, listen,
Yes, of
Victor.
course.
Victor, ¿tú quieres presentar principio o en 45 minutos? ¿Qué quieres?
You, yeah. Not hear me?
Yeah, Victor,
I'm okay.
¿quieres
Can you
presentar
hear me?
ahorita o en 45 minutos?
Can you hear me?
Yeah,
Can you hear me?
yes,
Can you hear me?
yes.
Yeah.
Trata otra vez. Tú estás en mute. Ok, ¿está bien? Victor, ¿puede oírme?
I'm okay.
Sí, parece. ¿Qué pasa con su internet hoy?
Can you hear me? Yes.
Sí, pero
Yes,
no,
no
no
problem.
Sí,
bueno.
profe Víctor, te escuchamos. Te escuchamos, sí. Continúa.
Sí, Victor. ¿Qué pasa con su internet? Normalmente es mejor. You can see how his internet is slow. It's not good today. Usually it's pretty good.
John, over there, I think there is some issue in Mexico.
Yeah,
I
I
can
think,
hear
I think
you
so. I think
clearly.
so. I think so
Another-
too. Yeah. Because I've been to Mexico. It's not very tough internet. Very tough.
Yeah.
Well, I'll tell you what, Edie, why don't we start with you and then we'll try to sort it out with Victor, okay? Okay, let me start
it's
now,
okay.
okay? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the honor of having Dr. Ehanga. He's a resident from Africa that's going to give a presentation. And before I turn it over to Dr. Ehanga, let's meet a few of the panelists. Good day, Amir. Unmute and introduce yourself.
Hello, everyone. Hello, everyone.
Who are you?
Well,
John, are you talking to me? I'm sorry, I didn't
Yes,
hear
yes,
you.
who are you? We want to know who you
Right.
are.
Hi, everyone. Sorry about
This is not
that.
America's Most Wanted.
Sorry. You know, I'm Emir. I'm a medical student from Iran. And yeah, I'm here for you. Just about that, you know, ask me everything.
Very good. Welcome. Welcome. Dr.
Thank you.
Cabulo.
Hello, everyone. My name is Kabulo. I'm from Democratic Republic of Congo. Currently, I'm final year neurosurgery resident at the University of Zimbabwe. Nice to meet you all.
And a longtime supporter. How about Nabaz Mohammed? Can you hear me okay? Perhaps not. Raciel, Mohammed, Adria. I know Adnan is there.
Yeah.
Go ahead, Adnan. Go ahead.
Yeah, it's me, Dr. Adnan Qasim from fourth year neurosurgery resident from Pakistan.
Okay, welcome,
Yeah, nice
Adnan.
to see you, everybody here. Good form. Yeah.
Okay, very good. Why don't we go ahead, Dr. Ehanga, and it's all yours, and thank you.
okay, thank you so much, Dr. Bennett. And this is a great opportunity for me to be invited here. I'm Dr. Eyanga Idimarse from Congo, Democratic Republic of Congo. I'm training in Uganda, Mulago National Referral Hospital in surgery at COSEXA.
Okay,
Thank you so much.
let me know when to start. Okay, let me straighten it up first. Is that okay?
Yeah.
Okay, tell me when to go forward.
Yeah.
Yeah, thank you so much. Today I'm presenting on a trauma course in Congo that we named National-Wide Scale-Up of a Context Specific Trauma Training Course in Congo. In this course, we are training medical doctors. In general, we are training healthcare professionals in how to handle trauma patients in Congo, nationwide. Next. Yeah, in this presentation, we are going to talk about, we are giving a background, objective and methods, results, conclusions, and challenges. And we will finish with a take-home message. Next.
I'm sorry. I'm sorry. Okay, there we go.
Yeah, in this background, I would people to realize with me that every injured individual should have access to and has right to adequate and effective trauma care. That is a life or limb saving. And this has been said by Dr. Ling Hong, WHO representative in Nepal. But how to do this? Next. Yeah, in this we are saying that trauma account for 10% of the global burden of disease in the world. And in this we have road traffic injuries, self-harm, falls, and interpersonal violence. All of these contributing greatly to both mortality and morbidity. And we have more than 5.8 million deaths worldwide due to injuries, mostly in children and young adults. So we have 1.2 million people died annually by road traffic accident. 90% of them are in low and middle income countries, unfortunately, with an estimated cost of more than 500 billions US dollar per year. Road injuries are the eighth leading cause of death globally in this part of the world. And middle income countries. Next.
Sorry. Okay, there you go.
And unfortunately, where we have all this burden, Africa is among that part of the world. And in Africa, we have a limited qualified surgical workforce, and specifically in sub-Saharan Africa region. And in here, we wanted to highlight the contribution of the College of Surgeons of East Central and Southern Africa, COSEX, over last 20 years. In these 20 years, COSEX has trained more than 340 specialist surgeons. Among them, we have 49 women's. And this course of a trauma course has been given in this region by Primary Trauma Care Foundation from England. And now this course is run in more than 70 countries worldwide. And COSEX has built a link with the University of Oxford called COOL, which is COSEXA Oxford Orthopedic Link Project. Under this project, many doctors in this region are trained. Among doctors in Congo, we are training them under this, but Congo is not covered by this project of COSEXA. Next. And we want to look at some causes of death in Africa, in Congo specifically. Over 10 years, from 2007 to 2017, we can see here some causes of death. We can see malaria, how malaria decreased, how respiratory infection decreased, HIV decreased. You can see here from 2007 to 2017, HIV have decreased over 64%. Why? Because there are much found in fighting HIV in the DRC. Malaria, same. But you can see road injuries from 2007, it has increased of 12%. And we can ask, why this increase? Why this increase over 10 years? And why this decrease over 10 years for HIV? The reason is simple. There are many projects for HIV, and for trauma, nothing is being done. No project for trauma, and that is why we decided to do something in Congo to train doctors, to train nurses, and trying to improve a little bit this situation, which is going in increasing. Next. Yeah, according those causes of most premature death, because you can remember I said these deaths are in those young people. We can see here again in 2007, malaria out went. It decreased over 37%, HIV 63.2%, but road injuries had increased over 7.5% of death, premature death. The reason is the same. People were not trained. A hospital could train its personnel, but not concerning all the country. Next. Yeah. What is about the most death and disability combined? We can see here other causes of this disability and death are going in decreasing. We can see them in red, congenital defect, but road injuries went in positive way, and it increased over 10%. HIV went in negative in decreasing, which and the reason we have already given this reason of this increase and decrease in other causes. Next. Yeah. What is the situation in DRC? Like we are talking about DRC, we can see here the population of DRC is over 80 million population. Compared to the population of the world, it's 1.13% of the total world population in DRC. But for this whole population, the situation we can see here, the situation is worse. Why? Because wars, road traffic accident, volcano, and those volcano and flood. But there is no well-established trauma training program in my country. But we are trying to do something for the country so that we can change this situation. In DRC, we can see that the program was introduced in DRC in 2016, in Congo Central region, and in Goma in 2019. And it was introduced by Surgical Club in Congo, which was created in 2008. Trauma training course would be the key response to this situation. And we can see here, this red color, this is Congo Central region and Kinshasa, and the other side, eastern part is Goma. And we can see that all the internal part is empty, no trauma training. Nothing is done in this other part. Only in two small parts we are trying to train and to change this situation. And we hope that one day we arrive to improve and to change the situation. Next, please. Yeah. What we aim and which method we are using. Here, this course we are giving in Congo, we use a method of 2-1-2 day course. It's like we train a group of like 20 healthcare professionals for 2 days. We deliver a course, a PTC, a primary trauma course for 2 days. And from this team, we choose like 10 people who will be trained like trainers. It's like the third day we do training trainers, the training trainers of these 10 people who will again train others for 2 days after their training of trainers. Increasing capacity on trauma care in DRC, We are aiming that, sustaining a trauma training approach. Strategic training hubs located in Goma and Kinshasa. Faculty members are from Surgical Club in Congo and serve as leader instructors. And all of them have been trained under COSEXA, which is College of Surgeons of East Central and Southern Africa. Participants are selected from hospitals in Goma and neighboring cities like Sake, Kiroch, and others. In Kinshasa, we select in hospitals from Kinshasa like we did in January this year. Next, please. Yes, like again, we want to train people. We can't come and directly we train. We need to know what level we found these people with. For that, we do a pre and post baseline demographic surveys. Then we do like a pre-cost test. After the pre-cost test, we train. After training, we do again a post cost test to know if how the cost has impacted, has changed their way of managing these trauma patients. And here, you can see how we do demonstration. This is demonstrative sessions. Like here, we have a chest of a goat on which we are training those medical professionals how to insert a chest tube. We can't say it like theory. We have to present by practice, and everyone has to practice how to insert a chest tube. Because this trauma patient, most of them, they will develop a pneumothorax, a hemothorax. So these people have to know exactly how to do it. That is why we put these demonstrative sessions, and we do it everywhere. We can see here, left side below, we can see some materials we use for chest tube and other demonstrative sessions. Here below at the right side, we can see we have a part of intestine on which we are showing these people, we are showing these doctors how to do like anastomosis. What we have to do. And this we do it when we are demonstrating what we call damage control surgery in trauma patients case. Please, next. Next, please. Yeah. As when we are training, we have done this pre and post test. We need to have results. We need to know which level pre-course and which level after course. Here we have some graphics like January 2019. We got like 51.8% of improvement. We follow when we reached the area, they had a level like 37.9% of success when we did the pre-course test. And after course, they reached like 89.7% of success, and the improvement was of 51.8% if we do the calculation. And here in East of Congo, we have delivered so far 4 courses as like 1 per term starting by January 2019. So far, 126 health professionals have been trained. 45 of them medical officers without surgical training. We capacitate them. 23% of nurses and 3% were surgeons. 29% were interns. And so far, the good news is that we have trained so far 12 new instructors in East of Congo who can train others without us because they have all capacities to do it. In May, we have got improvement of like 34.9% of improvement because they started by say 57.7% of success. Next, please. So, going to my conclusions, I can't finish this presentation without giving some challenges we are facing in East of Congo, in Kinshasa, for training these health professionals. So far, we have two training hubs established in Goma and in Kinshasa with this number of people trained. We want to sustain a scale up of trauma training, which is essential for increasing this capacity in DRC. We want this was a demand from COSEXA. We were asking to COSEXA to accreditate hospitals in Congo for training surgeons. Because if we have this in Congo, some hospitals training surgeons under COSEXA, we will improve this. And doing this will be the key response for this above local burden in DRC. Evaluation of the cost for long impact, we are doing this now because we have a survey. People have to tell us how the cost has impacted their management way of for trauma patients. So this survey is ongoing, and after this we are going to publish results this year, maybe in December at COSEXA conference or everywhere we can present it. And this, we have difficult accessibility and the lack of equipment in DRC. Some places there are not good roads. We have difficulties to access some area, and some other areas there was. Like not far from yesterday, I heard in Ruchuru, a car from Goma got in an ambush, and people died. Imagine if we have to go to train people and people are killed. You kill doctors who are going to train. This is very difficult, but we are trying to do whatever we can to help the population in our country. Next, please. So there is a take-home message to all people who are following this presentation. We want to implement a real trauma training in DRC because we need it. I present all statistics, I present how the situation is bad for trauma, and we need this course to improve a little bit the situation. And we are seeing how the Ministry of Education can insert this program in undergraduate and postgraduate program in Congo, and it will be a good thing. We are asking we ask to COSEXA to accreditate some hospitals in Congo for training surgeons, and surgical club in Congo can't achieve this mission without you, without people following, without other organizations. We need people to go with us because the way to go is still long and difficult, but it is not impossible because together we can. And in the following slides, please next, we are giving a message. It's an African proverb. Next, please. Next, an African proverb which says, you want to go fast, please go alone. But if you want to go far, please go together with other people. surgical club in Congo want to go together with other people, with Dr. Bennett, with other people. Thank you so much. Thank you, Dr. Bennett. Thank you. If there are some questions, we answer to questions.
Dr.
Yes, thank you very much. Okay, any comments or questions from the audience?
Thanks, Dr. Ehanga, very good presentation.
Go ahead.
Thank you. Thank you.
Okay, Dr. Kubulo, you have any comments since you're a neurosurgeon from the Congo? Are you there,
Yes,
Dr.
thank you so
Kubulo?
much. Thank you, Dr. Ehanga, for that beautiful presentation. Sorry, maybe I missed something. How many centers are you doing there? How many centers in DRC?
Yeah, so far we have created 2 hubs for this training under surgical club in Congo. We have one in Goma, which is used for training for doctors from Goma and surrounding cities like Kirocha, Sake, and some others from like Bukavu, you know. And the other one, we have another hub in Kinshasa. We are training people from doctors from Kinshasa. So far we have 2.
Okay. Any
Okay, thank you so
plans,
much.
any plans to increase in the future, in the near future?
Yeah, in the new future, we have a plan to extend. We have a plan to extend it in Maniema, in Kindu, Bukavu, Uvira, and Central Congo, like Kasai. We had a plan for this year. Unfortunately, not depending on our willingness, this corona outbreak has made us not to work, because we had a plan for April and July and October, training in Kasai, Kindu, and somewhere else. But this outbreak has stopped everything everywhere you are. You can't move. That was the plan for this year. But I think we are going to resume and do it.
This is on a somewhat related topic. Are there any active recruitment of like specialties like neurosurgeons and trauma surgeons? Or is the Congo trying to go to other parts of the world to get some doctors to fill? There's a shortage probably, right?
Come again?
I think Dr. Kabula, how many neurosurgeons does the Congo have? I think it's like 12, right?
No, so far we have 7.
7.
4 in the capital city, yes. 2 in Bukavu, east of the country, and 1 in Lubumbashi.
Okay, well, maybe you know the answer. Is the government trying to recruit neurosurgeons from other parts of the world? For example, China or something else, some other country?
Sure. Now they want to open school of neurosurgery here in Congo. So they'll be training locally neurosurgeons here. I think by next year, the school will be open.
Okay, that's good.
Sure.
Okay, more comments, questions? Koseka Heel, Africa. How you doing there?
Dr. John, Professor Víctor está aquí. Debe iniciar la presentación, ¿no?
Yeah, okay. I'm sorry, somebody has a comment? Go ahead.
Hello.
Latoya, go ahead.
Hi.
Hi.
My name is Adria. I'm from Brazil. It's not about that subject, but I'm very interested to know about the coronavirus in Congo, please, if possible.
It's a little off the topic, but certainly people can remark. That's all right.
I'm
It's
curious.
like a town meeting. Just bring up whatever you want. Okay, we'll discuss about the coronavirus later. Sorry, Adria, we'll
Hey,
just talk
John.
about it later, okay?
Hey, John, how are you?
Hey, how you doing? Come on, jump in, ask the question.
I'm just afraid to see how this presentation was thoroughly explaining us what's going on in Congo. I think the situation is generally in everything in French community countries, they have these limitations because most of the training and then programs to train surgeons, everything it's in English speaking countries, if I can say. So something I can advocate. So French country they have to do something like to be together and then find out how to improve the training or in trauma or whatever.
Did you hear the question, Hanga? Dr. Hanga?
Sorry, sir.
Did you hear the comment?
Yeah. I've heard the comment.
Okay.
I've read the comment. What is happening in Congo? We are here in Uganda, and we are following by radio and TVs, and things seem to be under control. The coronavirus outbreak seems to be under control as by information we are getting, and that is a good thing to hear from there, because that is our home, our homeland. So every time we are checking information, and we are having information like things are under control, and as a good Christian, we are praying for that.
Well,
Thank you, sir.
Dr. Hanga, we can actually have that as a topic next week if people want. Just state of the coronavirus in Africa. If you guys want to have a presentation, and we Adria, we could talk about that, what you were talking about. But why don't we go on to the next presentation? Thank you very much, Dr. Hanga. We're going to introduce Victor Hugues Perez, a gentleman I've known for a couple of years. I was introduced to him, Victor, by another neurosurgeon from Cesar Guandiki, a neurosurgeon from El Salvador. He says, you got to see this anatomist, Victor, from Mexico City. You remember that, Victor? Long time ago. And then I met Victor and saw his work. He's totally dedicated to neuroanatomy. And you'll see that when he presents. So welcome, Victor, and it's all yours. Just unmute yourself there, Victor.
Unmute. Yeah, unmute him.
Okay, it's okay?
Yeah, it's okay.
Sí,
Okay.
sí.
Is it okay?
Yes, it's good.
Okay. Hello, dear friends. Now we are going to have a lecture about forensic features in brain damage injury. Okay. This is very, very important. More than 50 of all cases of death encountered at forensic autopsy are associated with primary or secondary involvement of the nervous system, especially of the brain. The forensic pathologist must be able to judge or comment on nervous system injuries and or disease in death as well, as sometimes in living subjects. In the right side, we have a brain with a shotgun. These people die for the effects of a shotgun. So the importance of forensic neuropathology and associated neurology is reflected in the statement by Courville in 1964. Look, almost 50 years ago, he described by his own unhappy experience to learn that all too often a misinterpretation or an erroneous evaluation of a cerebral lesion has led to a gross miscarriage of justice. Official autopsies can be performed at the discretion of a forensic pathologist under the following circumstances: sudden and unexpected death of persons in apparently good health. So I think you remember the death, instantaneous death, the subit death. Number two, cases involving evidence or suspicion of violent death, especially of accident, suicide, or homicide. Deaths resulting from suspected medical practice and or negligence. This is now very, very common in most countries. This is growing up every day, the medical malpractice and or negligence. Deaths occurring during incarceration or while in police or institutional custody. Death at the workplace or due to toxic agents, cases of death involving victims of unknown identity, cases in which tissue loss due to decay and animal activity is so extensive that the victim's identity is unknown and neither the cause nor type of death can be established without autopsy. In autopsies of such cases, the forensic pathologist, neuropathologist, toxicologist, molecular biologist, or physicist must address the following issues depending on the nature of the case: identity of the victim, manner of death, natural or unnatural death, cause of death, process of dying, reconstruction of the process, causality linking an event with death. A manner of death. A strict distinction must be made between the manner and the cause of death. The manner of death differentiates between natural and unnatural death and will give further information on the mechanism of death: accident, suicide, or homicide. The cause of death also defines the cause of the irreversible cardiac and respiratory arrest or of the respiratory brain, as already mentioned. For example, you are seeing this image, and this is not enough to make a diagnosis. What we are seeing in this image, this is the necropsy of a person who died for a very great damage in the brain. So we can see a severe subarachnoid hemorrhage, and could be for different causes. Could be traumatic, could be an spontaneous hemorrhage. Later, we're going to analyze closer this picture. A distinction must always be made between the following manners of death: accidental death. The most common cause of accidental death in affluent Western societies is traffic accidents. The fatality often caused by mechanical brain injury. Accidental deaths in the workplace are comparatively rare. Such deaths usually involve the sequela of traumatic blunt impact, the death sometimes occurring after lengthy hospitalization and resulting from secondary complications. For example, this. So for most of us, there is no problem with the diagnosis of this parenchymal hemorrhage. Most of us, maybe all of us, think about an hypertensive cause of this hemorrhage. But in the another person who is not that do not have the knowledge of this pathology could think, for example, in cranioencephalic trauma. So that's the reason it's very important to make a correct diagnosis. For example, in this, in the left side, we have a contusion, brain contusion. In which area of the brain is located on? In the area of language. So if this lesion could be in the frontal lobe of the brain, maybe there is no problem. But this is in a very important area of the brain. In the right side, we can see a fracture. This is a fracture because of this person was hit with an object. Epidural hemorrhage is most commonly related to traffic accidents, especially rare in children under the age of 2 and in the elderly. Because in the elderly, this is because the dura is very attached to the cranium. So usually involves arterial bleeding. The lucid interval between the generation of injury and appearance of the first symptoms is commonly short. In very rare cases, however, the interval can last up to days. Is caused by local impact, loading of the head, and is thus nearly always associated with contact injury. Epidural hemorrhage arises from injury of the middle laryngeal artery and its branches near the impact site. So this was a person who died from a very large epidural hemorrhage. The person was 4 days in a hospital, and in that hospital, there were no CT to diagnose this large hemorrhage. In the first day, when this person was hit in the head, there was a CT, and the epidural hemorrhage was very, 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 very small. So brain surgeon did not think about a surgery because of the size of this lesion. But 4 days after, this was the result. So this is a video, and I want to show you in here why the symptoms of epidural. Okay, let me try to connect. Okay, I think then after I can show you this. Or yeah, let me go in the other.
Did you want to play the video? It's not playing, huh?
No, yes, it's not playing, but no problem. Let me see.
Okay.
Let me see.
Okay, no
Yes,
hurry. Just
yes.
take your time.
Okay, no problem. I think I have it in here. Okay, right. So we have the base of a brain. So can you hear me?
Yes.
Okay, here we have the third cranial nerve in the left side. I remove this temporal lobe, the tip of the temporal lobe. And look at this. What happened when a person have a epidural hemorrhage? The medial lobe of the temporal lobe is very attached to the third cranial nerve. And in this case, you are going to push the third cranial nerve. You will have mydriasis. And here we have also the posterior cerebral artery. So we could have also infarction of the occipital lobe. And the deterioration of the corticospinal tract is important in this kind of lesion. I'm going to put this video again in order to see the relation between this third cranial nerve, the mesencephalon, and also this posterior cerebral artery. You are not going to forget the symptoms that you can find in this kind of lesions. This is the oncus. This one is the oncus. And look what happened with an epidural hemorrhage. The corticospinal tract, third cranial nerve, and also the posterior cerebral artery. Posterior cerebral artery. Okay, so I'm going to show you a case of epidural hemorrhage. In a typical case, extradural hemorrhage occurs when a fracture crosses the midline meningeal artery, which adheres tightly to the inner surface of the temporal bone. Like in this case, this is the temporal bone. This is here is the course of the middle meningeal artery. And this fracture is going to lesion the middle meningeal artery because this artery adheres tightly to this inner surface of the temporal bone. About 24% of all instances of skull fracture are associated with extradural hemorrhage. This is the picture on this case. So now I want to show you a skull base made of resin. I made this skull base to show the cranial nerves, olfactory. The optic nerve is not. This is crossing here. The third cranial nerve, fourth cranial nerve, fifth cranial nerve, and the lower cranial nerves. So this is the course of the middle meningeal artery. It divides in two branches, one anterior, one posterior, one frontal, and one parietal. So if we have a fracture in the temporal bone, more or less 25% of these patients could develop an epidural hemorrhage. In color blue, we have the sinus of the skull base. This is the case of this person, an epidural hemorrhage. The forensic pathologist should remove all the dura attached to the inner surface of the skull base. All the dura matter should be removed to show any fracture of the skull base, like in this case. Look at this, the fracture of this person who died for defects of epidural hemorrhage. Edge of fractured bone can cause laceration of underlying dural arteries and less frequently veins. In rare cases, extradural hemorrhage is caused by lacerations of one or more branches of the venous sinuses or emissary veins. Extradural hemorrhage rarely occurs spontaneously. But what could happen if we have a fracture that crosses the right, the sinuses, the straight sinus, like in this case or in this case? So in these cases, we could have an epidural hemorrhage, venous origin. The epidural hemorrhage is most commonly related to traffic accidents, especially rare in children under the age of 2 and in the elderly. Usually involves arterial bleeding. This is, I think this slide is repeated, but I want you to see this very, very large epidural hemorrhage. This was an unfortunate child, a male child who died of epidural hemorrhage. This child was operated. This is a craniectomy, but child died because of this very large epidural hematoma. A space-occupying extradural hemorrhage will displace the brain, resulting in compression of the brain stem, herniation syndrome. This is a closer view of okay. Can you hear? Can you hear the audio, John?
I can hear you, but is there sound in the video?
Sound of the video? Okay, thank you.
Solo podemos escuchar a usted, profe. No, por de video no se escucha nada.
Okay, okay, thank you.
Otro español.
I'm going to put again, yes. No, I'm going to put again. Okay, this is the third cranial nerve, right cranial nerve. And look what happened when we have a displace of the temporal lobe. The uncus push the third cranial nerve and also the corticospinal tract, and can affect also this posterior cerebral artery. Of course, because this could happen, before this, we could have a severe affection of the consciousness because of the effect of this epidural hemorrhage. Let's go to see again this, this video. I think you are not going to forget this. Here we have the medial aspect of the temporal lobe, the uncus, and look the relation, the close relation with the posterior cerebral artery, third cranial nerve, and also the cortico-spinal tract. Look what happened in this kind of lesions. Again, third cranial nerve, very close to the uncus. Posterior cerebral artery, coming from basilar artery. This is the basilar artery. Okay, so this was the male child that died because of this severe lesion in the skull and in the brain. This is the effect of this epidural hemorrhage over the brain stem, specifically the mesencephalon. And in the case of this child that was about 4 years old, look the inner surface of the skull base. In the temporal surface, we can see this one. So this is a severe fracture. So let's go to see the closer view. Look at this very, very important fracture in the temporal bone, in the inner surface of the skull base. The medial temporal lobe displaces the brain stem with neurological deterioration, like in this case. So this was the child, very young child, with this severe trauma in the skull. So I am doing these models of a skull with resin, and then I put cranial nerves, arteries, and also veins and sinus in order to understand much better the anatomy of this region. For example, in here we have the lateral aspect of the right brain hemisphere. And what kind of other pathology we can find in the autopsies? For example, in this case, we have infection of the frontal lobe. This is the frontal lobe, and this is an infarction. The cause of this infarct, you can see the cause of this. Can you see these yellow plaques into the arterials? They are cholesterol plaques into the brain arteries. So this is the reason for this infarct. So this is a case of a very important subarachnoid hemorrhage. What could be the cause in here? This very large subarachnoid hemorrhage. Could be trauma. Is so rare to find subarachnoid hemorrhage like this in traumatic patients. The cause of this subarachnoid hemorrhage was this: an aneurysm in the middle cerebral artery. This was the cause. This is the middle cerebral artery, and this is a giant aneurysm located in the middle, in the right middle cerebral artery. So this is another specimen in which we can see the middle cerebral artery. The aneurysm that are coming from this middle cerebral artery usually are in the bifurcation of this artery. So this patient was involved in a car accident. This patient lost the consciousness and died. But what happened in the autopsy? Look at this. In here, you can see this liquid, this exudate, yellow exudate. So probably was not the trauma, was an emphysema in this patient. So this is the differential diagnosis that we should see in the autopsy cases of persons. This is just to see the base of this brain and to remember what happened with the herniation syndrome of the uncus. Here we have the base of the skull of this patient who died of rupture of a giant aneurysm. All of this is the subarachnoid hemorrhage. So this patient had sudden death because of the quantity of the blood into the subarachnoid space. This is the case. And the aneurysm. So this is an hemorrhage, a parenchymal hemorrhage, and the main cause of this parenchymal hemorrhage is hypertension. These are some pictures about acute subdural hemorrhage. This is in the left side. This is a severe traumatic damage brain with multifragmentary fracture. This is a subdural hematome. And look at this. What do we have in these pictures? Here we have the uncus in the right side, and in this case, in the left side, and look and compare the size of this uncus in this case and in the other case. This is bigger. This is edematous, and not only edematous, also an hemorrhage in this uncus. So look the relation between this herniation of the oncus over the brain stem and the third cranial nerve. This is a patient who died of this kind of hematoma. This is a fracture, the frontal, parietal, and occipital bones. And here we have a common subarachnoid, post-traumatic subarachnoid hemorrhage. This is the subarachnoid hemorrhage. So we can talk about this kind of hematomas, the subdural hematoma, in another lecture. So I think this is the end. Thank you so much for listening me.
Okay, Victor, thank you very much. I'm sure the students and the residents will see in the coming months the amount of work you've done. So we do appreciate it. And neuroanatomy is so important to a neurosurgeon. It's a constant, lifelong study, which surprised me. Okay, Victor, I'll get you off that, okay? You want to get off that screen? I can bump you off there. Okay, any questions or comments from the panelists for Victor?
Bueno, profe, muchas gracias. Muy buena charla eso. Hay mucho para aprender con esa presentación y las imágenes. Muy interesante. Muchas gracias, profe.
Thank you so much.
Okay, you just said a good job.
¿De dónde es nuestro colega?
De Pakistán.
Oh, tú eres de Pakistán, hablas perfecto español.
Sí, muy raro, ¿eh? Muy raro.
Sí, sí. Porque yo estudié en Cuba, por eso.
Okay, congrats.
Gracias.
Okay. Más, Stuart está ya, es un panelista he's from Ecuador. He's also bilingual. Okay, any other comments, questions from the audience? Okay. Okay, Victor, thank you very much, and thanks for taking the time to teach. You've done a lot. You know, Victor, I have to make a confession. We made a page for you on Neurosurgical TV. Did you know that?
No, I don't.
Let me show you, okay? I should probably make a big announcement about this.
Wow.
We should have drums and elephants and stuff, you know?
Wow, thank you so
Profe,
much.
esperaremos para la próxima charla. Otra vez.
Yes, we are going to talk about subdural and another kind of lesions.
Sí, sí.
For example, the gunshot lesions over the head.
Sí, claro,
Okay.
claro.
Okay, déjame
Muy pronto, muy pronto.
Let me show you this.
Thank you.
This page, and this is something for the youngsters to aim for, to have a picture, to have a page named after them on Neurosurgical TV. See, if you go to Neurosurgical TV/Victor.
Yes.
I don't even use his last name. So there he is.
Okay, yes, Perez.
I don't think you've ever seen this, Victor. I should probably have the drums playing or something, the trumpets.
Oh, yeah.
But there you go. Look, see, these are all and he's done a lot more. I haven't got a lot of them.
Okay, thank you so much.
But he has a lot of online videos for neuroanatomy. You can see them all.
Thank you so much.
Yeah, and this is when I was in Nepal. I have that little thing on my forehead. I don't know what it signifies. Something religious, but as you can see, Victor's done a lot of lectures.
Thank you very much.
Yeah. Well, you know, the only other people that have pages are Ipe and Yuha.
Yes.
So we'll add people as you go along. Okay, thank you very much, Victor. We're going to be starting the next presentation.
Thank you so much. Yes.
Okay, now we'll move on to the next presentation with Weil on temporal bone anatomy. And Weil, you're here, correct?
Yeah, I am here. Hi, John.
Okay,
Hi,
well, why don't you start introducing yourself, and I'll set up your PowerPoint, okay?
Okay. I'm Dr. Waif Rahman. I am a neurosurgeon from Sudan, working in Khartoum. Uh, I will present today for you the temporal bone. Okay. Nice to see you, Dr. Bakter. It was a great lecture. Thank you.
Okay, here we go. Let me know if you see it okay. Is it okay?
Yeah. Can you see my cursor?
Yeah, can you see the screen?
Yeah. Yes, I can.
Okay.
Can I share it from me better?
Yes,
Okay.
we can. We can see the screen.
Yes. Yes.
Yes, we see it.
Can you see my mouse, Dr. John?
Okay, let me do it again. I can't see it. No, I can't.
Let me do it for me, okay? Let me share it from me.
Yeah, it could be, maybe I need to change to reshare it.
Okay.
Okay, let me try it again.
Let
Okay.
let me try. Let me. Okay.
Right.
I'll do it.
Oh, you're gonna, okay, yeah, we'll try it. And if it doesn't work, I'll try to do it, okay?
Okay. Okay. Can you
Yeah,
see?
we can see it. You make it bigger?
Okay. Can you see my cursor now?
Yes. Let me see if you can see your mouse. Go ahead, move your, oh yeah, we can see your mouse.
Okay. Tell me when I should start.
Yeah, it looks good.
Okay. So our talk today will be about the temporal bone. As you know, the temporal bone. You hear me well, Dr. John?
Yes, we can.
Yeah. The temporal bone is constituted of 5 parts. As you can see, this is the lateral aspect of the temporal bone. It's composed of the squamosal part, this part, okay, and petrous part in the medial aspect, okay, and this is called the mastoid part, and this C-shaped bone in the external auditory meatus is called the tympanic part, and we can see also the styloid part, okay. So the temporal bone is constituted of 5 parts, as I said, the squamosal and the petrous and the mastoid and the tympanic and the styloid part. Starting by the squamosal bone, this bone is a thin bone, okay, and it's close the brain. It encloses medially the brain. Next slide, you can see this. Okay, we can approach the temporal bone area through 3 approaches, okay? Either from the middle fossa approaches, or from the lateral surface through the mastoid process, or through the posterior fossa, okay? We can talk about this, okay? As you can see here in the above this image in the middle fossa, the temporal bone is, if you start from anterior to posterior, there is a depression which overlaid by the Meckel cave for the trigeminal nerve. We call it the trigeminal depression, okay? And behind it, there is an eminence, we call it the trigeminal eminence. There is an elevation, and there is another depression, we call it the meatal depression, which denote the internal acoustic meatus. This depression is called the internal acoustic meatus. This is the meatal depression. And there is another elevation, we call it the arcuate eminence, which denote the superior semicircular canal. And behind this arcuate eminence, we can find this paper thin bone, which is called the tegment. Okay, it is the site of most leaks that happen on the brain. Okay, it overlie the tympanic and the vestibular area. Okay, so we can say it again. This is the depression for the trigeminal nerve, And there is an eminence called the trigeminal eminence, and another elevation we call it the trigeminal eminence, and another depression we call meatal depression denoted the internal acoustic meatus, and another elevation called the arcuate eminence for the superior semicircular canal. And there is a paper thin bone we call it the tegment. This is the posterior fossa, okay? And we can approach this through many approaches like retrosigmoid approach and lateral approach, and post-auricular transtemporal approaches. Also, we can approach the temporal area through this lateral approach through drilling of the mastoid process, okay? And we call it many approaches like minimal mastoidectomy variants or lateral labyrinthine type or partial labyrinthectomy, okay? Or transcondylar approach, or we can combine these approaches supra or infratentorial, okay? This is the tympanic bone, as you can see. This is C bone structure. This is the tympanic bone. It will make the anterior part of the external auditory meatus and the floor of the external auditory meatus and part of the posterior external auditory meatus. This is called the mastoid process. As I said to you, the mastoid process serves as attachment of many muscles. Those muscles are sternocleidomastoid and the posterior biliodigastric muscle and the longismus capitis muscle and the splenius capitis muscle, okay? There is also here a process, we call it a spike. It lies in the posterior superior part of the external auditory meatus, posterior to the external auditory meatus. This is the spike of Henel. This is spike of Henel. Posterior to it, there is a triangle. We call it meatal triangle, okay? This is the meatal triangle, which denote below this meatal triangle, okay, suprameatal, we call it suprameatal triangle. Below this suprameatal triangle is the mastoid antrum, okay? And the spike of Henel is it is at the level of the tympanic part of the facial nerve, okay? We can find the facial nerve about 1.5 centimeter deep to this spike of Henel. So there is a landmark in the lateral aspect of the temporal bone. We can use it as a marker. From the medial side of the temporal bone, this is called the squamosal suture, okay, which communicate the parietal bone, okay. So this is the temporoparietal suture between the temporal and parietal bone, okay. And this is the parieto-mastoid suture between the mastoid process and the parietal bone, between the parietal and mastoid. There is a junctional area between the squamosal bone and the parieto-occipital junction, which denote the lateral end of the vitreous bone. This is the vitreous bone, okay? This part is called the vitreous bone. We can see here the internal auditory meatus anterior to the, or medially to the anterior auditory meatus. If we do drilling here, we call it anterior vitrectomy, and posterior to the anterior auditory meatus, we call it posterior vitrectomy. So the internal acoustic meatus delineate the anterior or posterior vitrectomy, okay? And the vitreous bone has an anterior and posterior surface, okay? This is the posterior surface of the vitreous bone, which occupies by this opening we call the internal acoustic meatus, okay? Between this bone, there is a suture between the vitreous bone and the clivus called the vitroclival fissure, okay? At the top of it, this is called the vitreous apex. So the vitreous bone has an anterior and posterior surface and inferior surface, okay? This is the anterior surface. This is inferior surface which articulate with the occipital bone. So this is the inferior and posterior and anterior, and we have, as I said, this is the apex of the petrous bone. Okay, and so there is an apex. So this is the base. Okay, behind the base we find the groove which occupied by the sigmoid sinus. The sigmoid sinus is running here in this groove. Okay. As we can see here, also this is the zygomatic process of the temporal bone. Okay, we are looking from the inferior surface of the temporal bone. This is the mandibular fossa for the mandible, and this is the pterygopalatine fissure. Okay, the pterygopalatine fissure is the chorda tympani is running inside this pterygopalatine fissure, and this is the opening which the carotid will enter through. This is the carotid canal, the carotid opening. Okay, there is a cervical part, and after it enters, it will form the genu and then go inside the petrous bone. This is the petrous apex. This is, we can see here from inferior, this is the styloid process. Styloid process is projecting in the infratemporal fossa, and it will serve as attachment bone for the, it will serve as the attachment bone for muscles like the three muscles, the styloglossus and stylopharyngeus and stylohyoid muscle. Okay, between the mastoid bone and the styloid process, this is the foramen. This foramen is called stylomastoid foramen. This is stylomastoid foramen is the exit foramen for the facial nerve to the extracranial compartment. Okay, after that, it will divide into 5 divisions, as you know, from the tympanic and zygomatic and buccal and marginal mandibular and cervical part. Okay, this is the jugular fossa. Okay, this is the jugular fossa. This is the jugular fossa, and this is the mastoid notch. Okay, through this notch will go the branches of the occipital artery to supply the posterior dura, and emissory veins from this, also from this bone. There is a groove here in the mastoid process, serve as attachment for the posterior belly of the gastric muscle, and anterior to this, there is a connective tissue here, anterior to the fascia of the posterior digastric muscle, which the facial nerve run into it. So the anterior fascia of the the anterior part of the posterior belly of the gastric muscle connective tissue serve as a landmark for the facial nerve in the extracranial compartment. So this is also an inferior view. You can see here the styloid process. Okay, this is the carotid opening, the carotid canal, external opening of the carotid artery. There's the carotid. This is the jugular fossa, and this is the mastoid. As this groove is called the mastoid groove. Okay. This is the tympanic part from below, and this is the mandibular fossa, and this is the petrous bone, and this is called the apex. Okay. We can see also here from below, also the styloid process, and this we can see many openings here. The foramen lateral, okay, and the oval foramen for the mandibular division of trigeminal nerve. Okay. So as I said, the temporal bone from anterior to posterior, there is an impression for the trigeminal nerve ganglion called the trigeminal impression, and there is an eminence here, an elevation called the trigeminal eminence, and there is then a depression called the meatal depression, denoting the internal acoustic canal. And there is an elevation, another elevation called the arcuate eminence, denoting the superior semicircular canal, and a slopy bone, paper thin bone called the tegmen, which overlie the tympanic cavity and the mastoid antrum area. Okay, this is the squamosal bone. Okay, another view. This medial surface, as you can see here, this is the internal acoustic meatus anterior to a drilling of this area called anterior petrosectomy, or can immediately, as you can see, the temporal the petrous bone is serve as is a compact bone. Okay, and it contains the cochlea inside it, and contain the vestibule, and contain the semicircular canals, and contain the the facial canal, and contain the carotid canal. Okay, here we can see the internal acoustic meatus from medial side. Okay, and this is an inferior to it, inferior, and medially there is a cochlear aqueduct. Okay, and this is the vestibular aqueduct, which lie posterior and inferior to the internal acoustic meatus. And this groove, as we said earlier, this is the groove for the sigmoid sinus. Okay, it will drain into the jugular foramen. As you know, the jugular foramen is composed of 3 compartments. The anterior part is petrosal part for the inferior petrosal sinus, and the intrajugular compartment for the 9 and 10 and 11 cranial layer, and the posterior part is called the sigmoid part, which is occupied by the sigmoid sinus. Okay, this is a view showing the internal acoustic meatus. As you can see, there is a transverse crest that separates the superior compartment from the inferior compartment. The superior compartment is further divided into anterior and posterior part by the crest called vertical crest or Bell's bar. Okay, the anterior part of this is occupied by the facial nerve. Okay, and the posterior part by the superior vestibular nerve called the superior vestibular area. And this part below the transverse crest is occupied anteriorly by the cochlear, called the cochlear area. So it's occupied by the cochlear nerve, and posterior to it, there is an opening for the inferior vestibular nerve. You can see here on the inferior vestibular area, there is an opening for the singular and utricle nerve. Okay, so this is the singular foramen. Okay, it's a division from the inferior vestibular nerve. In the lateral part of the temporal bone, there is a landmark, as I said. There is an important landmark. We call it the suprameatal crest. This suprameatal crest above the mastoid. Okay, the supramastoid crest. This crest is denoting the floor of the middle fossa. So this is the floor of the middle fossa. Okay, another landmark, as we said earlier, this is the suprameatal triangle for the tympanic antrum. Okay, the joining area between the squamosal suture, this is the squamosal suture beginning from here and going above and then down to meeting point of this is the mastoid parietal suture. This is suture. This is the mastoid parietal suture. Mastoid parietal suture will meet the squamosal suture, and this denotes the lateral margin of the petrous bone, and it is also denoting the superior or the anterior part of the junction of between the, as you can see here below, between the transverse sinus and the sigmoid sinus. This is the sigmoid sinus, and this is, as we said, this is the suprameatal crest, which denoting the floor of the medial fossa. This is the floor of the medial fossa. And this is the squamosal suture. And this is meeting point between the squamosal suture and the parieto-mastoid suture. So this is denoting the superior part of the junction between the transverse sinus and the sigmoid sinus. This is the upper end of this junction, and the lower end of this junction is denoted by the asterion, is another landmark. Asterion is formed by connection between the lambdoid suture and the parieto-mastoid suture and the occipito-mastoid suture. So the asterion lie in the anterior part of the lower part of the junction between the transverse and the mastoid sinus, and the junction between the squamosal and parieto-mastoid denoting the upper margin of this junction. So the drilling in the posterior fossa should be medial to this, or posterior to the asterion. If you do a Pierre in the asterion, you will open at this junction at a level. Okay, you can see after here, after we do cortical mastectomy, you can see this is the sigmoid sinus. Okay, so this approach is divided into anterior to this sigmoid sinus, we call it pre-sigmoid approaches, and posterior to this sigmoid sinus, we call it retro-sigmoid approaches. We can see here the asterion, as we said. Okay, this is the spike of Henle. The spike of Henle lie in the superior and posterior, so posterior part of the external auditory meatus. As we said, it's denoting the tympanic part of the facial nerve. Okay, this is the spike of Henle, lying the superior posterior part of the external auditory meatus. This is the round window, and this is the promontory of the vestibule. Okay, the promontory is the medial wall of the middle ear, and this is the tympanic bone. As we can see, this is like a C-shaped structure which form the anterior and the floor and the posterior part of the external auditory meatus, the bony part, because it have two parts, the cartilaginous and the bony part. As we can see here, this is a medial view of the temporal bone. This suture is called the petroclival suture between the petrous bone and the clival and the clivus. Okay, and which the inferior petrosal sinus run into this fissure. This is the internal acoustic meatus. This is the subarcuate fossa. The subarcuate fossa is like behind the internal auditory meatus. So there is an opening for the subarcuate artery. The subarcuate artery is a branch from the ICA, a loop of the ICA. Sorry. This is the endolymphatic duct here side. Okay, as we can see, this is the jugular foramen which lie between the petrous bone and the occipital bone. Okay, we divided it into 3 compartments, as we said. Also, we can see here in the image of B, this is the Meckel cave for the trigeminal ganglion. As we said, there is a trigeminal impression here. Okay, this is the facial nerve, the motor and sensory part, and this is the abducens nerve bearing this dura at the level of the inferior petrosal sinus. Okay, through the Doralus canal. So in the inferior petrosal sampling, we can cause damage of this abducens nerve and cause abducens nerve palsy. This is the internal acoustic meatus, occupied by, as we said, the superior part and the inferior part, superior anterior by the facial, and superior posterior by the superior vestibular, and the inferior anterior by the cochlear nerve, and the posterior inferior by the inferior vestibular nerve. This is the posterior semicircular canal, which lies parallel to the base of the petrous bone, and this is the superior semicircular canal. If we drill the superior semicircular canal, it will take us to the middle fossa, and we would drill the posterior semicircular canal, it will take us to the posterior fossa. Okay, as you can see here, this is the arcuate. As we said, this is the subarcuate fossa, and this is the subarcuate artery. The internal acoustic meatus, if we can, in the posterior approaches, in the hereditary sigmoid or other approaches, we are going to drill the posterior lip of the internal acoustic meatus. We must take care not to damage. This is the common cruise. The common cruise is the meeting point between as know, we have an ambulated and non-ambulated end of the semicircular canal. So this is the meeting point between the posterior semicircular canal and the superior semicircular canal. We call it the common cruise. So in the proto-sigmoid approach, we can damage the common cruise or the posterior semicircular canal or the vestibule of the vestibule. Okay. Here we also see the facial nerve. Okay. And this is, as we said, this is the superior vestibular nerve, and this is the inferior vestibular nerve, which give branches to the utricle nerve and singular nerve and saccular nerve. As we know, the petrous bone also have the carotid canal. This is the petrous segment of the carotid artery, okay, running inside the petrous bone, and this genu, and this is through this cervical segment called, according to the division of the classification of internal carotid artery according to Rotor. This division is called the C2. Okay, C1 is the cervical part. Okay, you can see this is the inferior petrosal sinus. Okay, as we said earlier, if we do sampling in the inferior petrosal sinus, we can cause complication by damaging this 6th cranial nerve palsy. Okay. This is the sigmoid sinus, okay, running upward to form the jugular bulb and then down to the jugular foramen. In this view, we can see here the vestibule, and this is the facial nerve in the anterior compartment, as we can see, and below it in the anterior compartment, this is the cochlear nerve going to the cochlea. The cochlea is composed of 3 terms. This is the basal term, anterior term, this is a middle and apical term. In this view G, we can see here this is the facial nerve, okay, in the anterior compartment, as we said. Below it in the anterior compartment is the cochlear nerve. And here in the superior compartment, in the posterior, this is superior vestibular nerve, as we said earlier. This is the in here we can see this, what's this foramen. This is oval window, okay, it occupied by the foot process of the stapes. This is the ampulla of the superior semicircular canal. This is the ampulla of the lateral semicircular canal, and this is the ampulla of the posterior semicircular canal, and this is the endolymphatic duct. As we said earlier, this is the cochlea, and we're facing now the basal part of the cochlea. This is the basal term. We can see this. We can see here in this skin. This is the external auditory meatus, separated by the tympanic membrane from the middle ear, and this is the inner ear. This is the ossicles of the middle ear, okay, middle ear cavity. This is the malleolus, and this is the head of the malleolus, and this is the incus, head of the incus, and this is the stapes, which by the oval window. The head of the malleolus and the incus is lying in this compartment. We call it the epitympanum. This is the tympanic cavity. So this cavity is called the epitympanic cavity. This is the tympanic cavity, and this is the Eustachian tube. This part is the medial wall. This is the medial wall of the middle ear, and we call it the promontory. And this is the round window, which is covered by a thin membrane. Okay, and this is the cochlea. Okay, the basal turn and the apical turn and the middle turn. Here we can see, as we said earlier, we can approach the temporal bone area by drilling through the lateral part of the temporal bone through the mastoid process. So this is the mastoid process, okay? And this nerve is the facial nerve is in the extracranial compartment, okay? This is the vertical segment. This is the spike of Henle. As we said, it is at the level of the tympanic part of the facial nerve, the horizontal segment of the facial nerve, and this is the tympanic bone, and this is the tympanic membrane. Okay, and this is the fossa of the mandibular fossa. After we drill this mastoid cortical mastectomy, we can see here, this is the part of the facial, we call it the mastoid segment. This is the vertical segment inside the mastoid. This is the mastoid segment, and this is the sigmoid sinus, and this is the petrosal, the superior petrosal sinus. Between the superior petrosal sinus and the sigmoid sinus and this dura, here we can, after drilling of this bones, we can find the middle fossa dura. This angle is called the sinodural angle, okay? As you can see here, this is the posterior semicircular canal in parallel to the sigmoid sinus, and this is the lateral semicircular canal, okay? And this is the antrum. Below here, you can see this is the mastoid segment of the facial nerve joined by the chorda tympani, which go to run in the tympanoceroid fascia. Okay, this bony, but this is the bony ossicles of the middle ear. Okay, this is the lateral semicircular canal, and this is the superior. The posterior semicircular canal, and this is the jugular bulb. As we can see here, this is the chorda tympani, and this is the promontory. The promontory means the medial wall of the inner ear. Okay, this is the mastoid part. This is the vertical segment, and this is the tympanic segment, which lie at the level of, as we said, this is the horizontal segment of the facial nerve, which lie in the level of the spike of Henle. It run below the lateral semicircular canal. This is the lateral semicircular canal. After drill, it lies below this lateral semicircular canal. So we have marks, as we surface landmarks, as we said. This is the spike of Henle at the level of the tympanic segment, as I said earlier. If we drill this mastoid, we can see this, and taking this bone, okay, we can see this a dura. This is the middle fossa dura, and there is a triangle. We call it Trotman triangle. This Trotman triangle is lie between this otic capsule anteriorly and the sigmoid sinus anterior edge posteriorly and the inferior edge of the superior petrosal sinus above and the jugular bulb below. So this is the borders of the Trotman triangle. Through it, we can reach the posterior fossa and reach the CB angle area. Okay. You can see here, this is the superior petrosal sinus, and this is the sigmoid sinus, and this is the jugular bulb. There is, as we said earlier, there is an angle here between the sinus and the dura. We call it the sinodural angle. Okay. Here in below, we drilled. We have, as we said, many variation in the approach through the mastoid, either by taking partial labyrinthectomy or transcondylar approach. There is many variants according to the status of the patient, according to the site of the anatomy of the tumor. Okay. This dura and this approach is limited below, as you can see, by this jugular bulb. If the jugular bulb is high, this space will be narrow, okay? And we can cause damage of this jugular bulb and causing air embolism, okay? So there is a distance between the superior petrosal sinus and the inferior part, which is occupied by the jugular bulb. It is about 40 millimeter on the left side, and on the right, on the left side about 60 millimeter. On the right side is about 40 millimeter, and there is an antro posterior diameter here between the otic capsule here after removal and the anterior margin of the sigmoid sinus. This space is about 8 millimeter on the right and 7 millimeter on the left ear. Okay, pause it different. This is the facial nerve. After you scrutinize this nerve by drilling all these semicircular canals. Okay, after opening of this dura, we can see this is the vestibular nerve. Okay, and this is the trigeminal nerve, and this is the pica. Okay, and this surface of the cerebellum is the petrosal surface that facing the petrous bone. As we can know, the cerebellum has three surfaces: the tentorial surface and the petrosal surface and suboccipital surface. This is the petrosal surface that facing the petrous bone of the petrous bone. Okay, petrous surface of the petrous bone. We can see here what we call the adductus of the mastoid antrum, which connect the tympanic cavity to the mastoid air cells. Okay, we call it the adductus to the mastoid bone. So it is a connection between these two cavities. You can see here the facial in this schema, the facial nerve running here. Okay, and go through the facial canaliculus here. This is called the tympanic segment. This is the horizontal segment, as we said earlier. Okay, and this is the vertical segment. This is the mastoid part. We call it mastoid segment. You listen to me?
No. I'm sorry, there may be a little interference. Hold on.
Oh, okay.
Sorry about that.
Okay. Okay. We can see here inside the mastoid, this is the labyrinthine. Okay, we can see a better picture here to understand the parts of the facial nerve better. The facial nerve, it has a cisternal segment in the cistern. Okay, this is the facial nerve arising from the brainstem. At the hand, this is the cisternal segment, and this is the meatus. After drilling of the meatus, this is called the meatal part. So cisternal segment, and we call it the meatal segment, and in this part, which is related to the cochlea, before taking this genu, this part is called the labyrinthine segment because of intimate relationship to the cochlea. We call it the labyrinthine segment. After that, we can find this genu. This is called the second genu because the first genu is inside the brainstem itself around the abducens nerve nucleus. Okay, and this segment is called the earlier. This is the lateral semicortical canal. So this segment of the facial nerve that run below the lateral semicortical canal with intimate relationship to the tympanic cavity, so we call it the tympanic part. After that, we have this horizontal segment. We have a vertical segment we call the mastoid segment. So again, we have this external segment from the brainstem to the internal acoustic meatus. From the internal acoustic meatus, this is the internal acoustic canal. We have the meatal segment, and at the level of the cochlea, we have labyrinthine segment. And this is the genu from which there is a branch called important skull base landmark. It's the greater petrosal nerve, which joined by the sympathetic part of the sympathetic franco around the carotid, petrous carotid, to form the median nerve. Okay, and this is the trigeminal nerve. This is the mandibular division. Okay, we can see here this Y-shaped lamp. Okay, which made by this internal acoustic meatus and this cavity, which call and this tube, which call it the Escherichian tube. Okay, and this the other side of the lamp denoting the external acoustic meatus. This is the external acoustic meatus. This is the Escherichian tube, and this is the internal acoustic canal. Okay, this is the vestibule. Okay, as we said earlier, and the above slides. Sorry, but I have to connect my computer. Okay. So we have three approaches to the temporal bone area, as I said earlier, through the posterior fossa, through the retrosigmoid approach or bilateral approach, or through the middle fossa approach. Okay, and this is view. We are going to talk about the middle fossa things. Okay, and we talked in the later slides about the lateral wall or through the mastoid approaches. So middle fossa approaches, posterior fossa approach, or lateral wall through the mastoid process. This is the middle fossa approach. We can drill over the meatus, the meatus, and find any tumor which is by the internal acoustic meatus, okay, by drilling over the internal acoustic meatus. So this is one variant of the middle fossa approach by drilling of the internal acoustic meatus. It have this wide area we call the porus, and this narrow area below we call it the fundus. So drilling is in the fundus will be so tight, and we can cause damage either to the facial nerve itself or the cochlea, or so we can start our drilling on not in this tight area, in this porous area, okay? And we can approach the internal acoustic meatus, any tumor lies, small tumors, without damaging the vestibular nerve. So by definition, this approach is designed for the preservation of hearing. Anterior, we can drill also the anterior vitrectomy. As we said earlier, the anterior vitrectomy is done anterior to the internal acoustic meatus. So the anterior acoustic meatus will divide the anterior and posterior petrous bone. This is anterior vitrectomy, and we can drill this anterior petrous bone okay, and to approach the area of the upper anterior of the posterior fossa and the upper part of the clivus. Another entity approach, other than the internal acoustic meatus, is the extended middle fossa approach. Okay. Another variant is called the subtemporal preauricular infratemporal fossa approach. Okay. Which in this approach we combine the infratemporal fossa approach with the petrous bone and the apex and the posterior fossa and to reaching the posterior fossa and the orbit. In this image, as you can see here, this is the fish. We can see here the superior vestibular nerve, and this is the inferior vestibular nerve, and this is the facial nerve. This is the meatus segment, as I said, inside the meatus, and this is the cisterna segment inside the cister, and this is the labyrinthine segment, and this is the geniculate ganglion of the facial nerve, and this is the tympanic segment of the facial nerve, the horizontal segment, and this is the vertical. And then we will find the mastoid segment, which is the vertical segment. Here above, we can see this is artery. We call this the middle meningeal artery through the foramen spinosum. It gives a branch, as you can see here, to the geniculate ganglion of the facial nerve. So if you lose this artery, we can cause the facial nerve palsy because it gives blood supply to the geniculate ganglion of the facial nerve. And in the elevation of the, also we can cause damage of the facial nerve in the elevation of the period of the middle fossa dura. During this elevation, we can avulse this geniculate ganglion and causing facial nerve damage. Rotem found in about 16% of the specimen of the temporal bone that bone above the geniculate ganglion can be adhescent, no bone over this geniculate ganglion to cover it. In 16% of this patient, he studied about 100% of specimen and he found this. Okay, and also there is maybe a 50% adhescent part of the petrous carotid inside the middle fossa. So we must take care during drilling of this type of surgeries. All this beautiful picture is taken from the Rotem book. It's a beautiful book. You can see here also below, this is the geniculate ganglion again. This bone which separate, as you can see, this bone, earlier I said this bone separate the facial nerve from the vestibular nerve. We call it Bell's bar. Okay, this is the vertical crest. This is the vertical crest we talked earlier about. Again, this is the meatal part, and this is the labyrinthine part. It's related to the cochlea. Cochlea here we have the apical turn, middle turn, and the basal turn. After this labyrinthine segment, it will change to the geniculate ganglion from which arise the greater petrosal nerve. Okay, and this is horizontal segment, as we said earlier again and again. This is the tympanic part of the facial nerve related to the lateral semicircular canal and go below the semicircular lateral semicircular canal. We said again, this is the vertical segment of Bell's bar that separate the facial compartment from the vestibular compartment in the superior part of the internal acoustic canal. This is the semicircular canal. This is the superior one, and this is the lateral semicircular canal, and this is the posterior semicircular canal. It faces in the parallel to the posterior surface of the petrous bone. Okay, this is the vestibule. Okay, and this is the cochlea. This is the singular branch going to the cingulum. Okay, the singular branch, electrical branch, as we said earlier, it arises from the inferior vestibular nerve. think there is many repetition in these slides. I took many time. Sorry for this long time, but I want to emphasize that the petrous bone is an important bone. You can approach it through many sides, from the middle fossa side, from the posterior fossa, from the lateral wall through the mastoid. Okay, there is an important landmark. We can use it through the surgery. Okay, so thank you. This was a long talk. Thank you.
Well, thank you very much, Boyle. And your internet was working today. Good.
Yeah, can I share, Dr. John, something?
Yeah, let's open it up for questions or comments. And I'll get you off the screen there. Okay, any comments? I know anatomy is pretty straightforward, but maybe somebody has some comments to make.
Thanks, John. Such an excellent presentation by Dr. Weil. Very impressive work. The pictures he shared about temporal bone, very interesting. And there's a lot to learn from him. Thanks a lot.
Thank you. Can you see my picture now?
Go ahead.
Yes, we can. Yes, we can.
This is a 3D model. You can see it?
Yeah, yeah.
Okay, I want to simplify things. As you can see, this is a 3D view. This is the external auditory meatus, okay? And this is the, sorry.
3D anatomy, right? 3D neuroanatomy.
Yeah. Learning of the anatomy is changing. Okay, this is the tympanic membrane, okay? Behind it lies the middle ear, okay? This is the malleolus and incus and stapes, okay? This yellow thing is the facial nerve. We can grab it from here, okay? You can see it from here. This is the internal acoustic canal. So this is the meatal segment of the facial nerve, okay? And this is the labyrinthine segment, and this is the cochlea. This is the basal turn, and this is the middle turn, and this is the apical turn. And this is the genu of the facial nerve after this labyrinthine segment. So it's called labyrinthine segment because it's related to the cochlea. This is horizontal or transverse tympanic segment. It go below this semicircular canal. This is the lateral semicircular canal. So this is the lateral semicircular canal. This is superior semicircular canal. This is the posterior semicircular canal. Below the lateral semicircular canal, going the tympanic segment. So this is the horizontal segment. And this vertical segment goes through the mastoid. This is the mastoid segment, okay? So I just want to say to you these all things to simplify the course of the facial nerve and the vitreous bone, and to see the relationship of the, this is the tympanic segment, as I said, it is in intimate relationship to the bony ossicles here. So we can, from the doing otoscope, if you do an otoscope, you can see the facial nerve through it, okay? This is what this structure, this is the chorda tympani joining the mastoid segment of the facial nerve. Thanks.
Okay.
I would like just to share this 3D view. I like it. I want to share it.
Okay, more comments, questions from the panelists? Okay, if not, okay, wow, thank you very much. We look forward to your next presentation.
Hello,
And
Dr. Bennett.
yes, go ahead.
Yeah, I want to thank Dr. Weil for this long and great presentation, which has recalled us about this anatomy. Thank you so much, Doctor, and maybe another time people will need to hear from you. Thank you so much.
Thank you.
Thank you, Thomas. Thank you so much.
Dr. Weil, thank you for beautiful presentation. You have well taken it, and we appreciate it. It's just that it takes a while for some younger colleagues to pick up these things, especially at surgery. Drilling down the facial canal is always not very easy for some, but they have to master the art of drilling.
Yeah, absolutely. You're right. You're right. It's a long journey to learn this experience.
I'm just going to get you off the screen there. Okay, there we go. Okay. Anybody else want to say something before we go, before we close? Dungaga, you're here from Nigeria, I see.
Yes, I'm here, Dr. Bennett. I came in pretty late though, but I really enjoyed the terminal part of the lecture. Thank you so much, Dr. Weil.
Thank you. Thank you. You're welcome.
Thanks for coming, Dung.
you,
Okay.
Dr.
Hello.
Yeah, go ahead.
Hello. Hello, John. Hello, Dr. Ryle and Dr. Rania.
Yes, hi.
Thank you so much for this great presentation and very informative. And we hope to hear a lot from you soon also. Thank you.
Thank you, Dr. Rania. Dr. Rania is one of the most enthusiastic registrar in our rotation. Thanks for your coming and support. Thank you.
Thank you. Thank you so much.
Very good. Very good. Joanna, is there Joanna in the house? I don't know if there's a Joanna in the house. Perhaps not. Okay. Okay, very good. Oh, and before I go, I want to show you guys something. This is like a commercial. This is another webcast that's going to occur in like an hour. Shari 1 malformations. Do you see the screen okay?
Yeah, yeah.
Okay, Shari 1 malformations, diagnosis and management part 1. I put the link. I'm going to put the link in the chat for you to come in if you want to come in. Okay.
Okay, okay.
And that's in about an hour.
Okay, I will connect.
And let me put that. I'll go off the screen. Thank you, everyone. I'm just going to stop recording here. Okay. Yeah. Let me put that. Let me put the link in there right now for the next talk in about an hour. Okay. Yeah, we got lucky, Weil.
Yeah.
With the internet.
Yeah, yeah.
It worked fine. Not one hitch. It's funny, huh? Some days. Okay, does everybody see that link at the in the chat? That's the link.
Yeah.
That's the Zoom link to come into the next talk in 1 hour.
Yeah.
Yeah.
Okay, we will push it up to the Telegram chat group and then let people be aware. That
Oh, that would be great. That would be great. That would be great.
Thank you, John.
Okay, very good. Okay,
See
Dr.
you
Weil, thank you. See you. Bye-bye.
Thank you.
All
Bye-bye.
right, Dr. Weil, thank you very much.
Thank you. Thank you. Bye-bye.
All right.
Thank you so much, sir.